of severely deformed those and this patient came to me with a deformed nostril with deviated nasal dojum. This patient also came to me with uh, quite concave nasal dojum with asymmetric nostril with deviated, tilted columella, and this patient had problem of tilted, quite retracted columella, a concave nasal dojum, and this patient has a horrible skin problem caused by infection with anaplastic implant. All these problems have common denominator of a loss of septal cartilage framework and contracture of irreversible damage of skin soft tissue envelope, causing retracted columella and ala with deficient skin, and underlying under the skin, they usually have deformed upper lateral and lower lateral cartilages. Rhinoplasty for this deformed nose is quite like rebuilding a broken house. So in order to rebuild a broken house, what we have to do first is rebuilding a strong pillar with strong timber. For me, it's costal cartilage in most cases. So rebuilding a pillar is a major septal reconstruction. We can rebuild the pillar, many different ways. Luckily, if we have remaining septal edge strut, we can exploit the septal edge strut by adding septal extension graft on a side, and you can add this septal extension graft on one side, so we can reconstruct the edge strut in many different ways by adding two extended spreader graft and two batting graft, two extended spreader graft, and adding one end-to-end septal extension graft. Among different ways of mesoseptal reconstruction, the way I like most is placement of the two extended spreader graft, sandwiching one septal extension graft, sometimes supported by one horizontal batten type supporting graft. Yeah, this provides me with quite flexible and stable support by which I can project, rotate, derotate the main framework of the nose. And once I can get strong support, then I can add the thick grafting as shown in this video. But if the patient doesn't have enough septal cartilage, what we can do is reconstruction of severely damaged cartilage by placement of the bypass edge grafting using costal cartilage. This is actually the integration of the columnar strut plus dorsal implant, as shown in this illustration. And the dorsal part can be long, can be intermediate length as this, and this can be short, covering just cartilaginous dojum. So this is the intraoperative photo of a bypass eye graft. This is quite useful technique you have to understand. And once we have a strong pillar and pedestal, then we can do the roof work. It can be tip and dorsal augmentation. And tip grafting is important for final shaping of the nose. So I use tip grafting mostly done by ear cartilage or septal cartilage. Dorsum can be augmented with silicone or Gore-Tex, but the recently my favorite technique is using glued coastal cartilage fashioned with newly developed mold. This is my recent, very recent publication appearing in PRS. So when I use this technique, I disassemble this mold and I place first the perichondrium or fascia at the bottom, and then glutatized cartilage is mixed with the glue, and then finally I have a dorsal implant covered with on one side with fascia or perichondrium, and then it's shaped like this, and this is nice dorsal implant material. In this case, it is one side is covered with homologous fascia. But you have to understand that rhinoplasty is a sculpture with a draping. So we can do very nice work in sculpting skeleton. But the real important factor in successful rhinoplasty is the drape. So if you don't have good skin soft tissue in an envelope, you cannot perform a nice rhinoplasty. So in that regard, in severely damaged patient with badly damaged skin, in extreme case, you sometimes need to have forehead flap. And conchal cartilage composite graft is an alternative option we can use. This is ear cartilage composite graft. So in most cases of the deformed nose, the mixed combination of a short nose and cellulose, and the mix is it's usually consequences of complicated revision scenario. So this patient developed this ugly short nose because of the silicone implantation done elsewhere. So I opened her nose and I harvested her costal cartilage, and I'm extending her central compartment with costal cartilage, and quadriceps extension graft was placed in an end-to-end manner, and it was further supported with horizontal baton type graft, and further supported with additional septal extension graft, and dome division was done to cover this elongated central compartment. Additional thick grafting and fat was added for the tip, and the skin was covered. And this is post-op result. As you can see, I was able to derotate the nose, and dorsum was augmented with glutatized costal cartilage. As you can see, her dorsal concavity was improved. This was a similar situation with contracted skin and upturned nose. And after reconstructing her septal cartilage framework, I augmented her nasal dorsum with glutatized costal cartilage, so her dorsal concavity was improved, and I was able to derotate her nose. Another patient who developed concave nasal dorsum with and nostril asymmetry after the failed rhinoplasty with the silicone. So after reconstruction of the septal cartilage framework, I was able to correct her nostril deformity, and this is relatively early post result, but as you can see, her nostril deformity was nicely corrected, and her dorsal concavity was nicely improved. This is the power of the glutatized costal cartilage. This patient from United Arab Emirates had 4 times rhinoplasty. As you can see, she has quite complex nasal deformity. We can imagine that her lower lateral cartilage is badly damaged. So what we have to do is re-stabilizing the central compartment by placement of the costal cartilage central strut with bilateral extended spreader graft and quadriceps extension graft. In the same way, I re-established the central support, and Dojum was augmented with glutathione coastal cartilage. Here she is. This patient developed a saddle after trauma, and the one attempt by other surgeon was failed. So she was referred to me for correction of the saddle. So I opened her nose and I corrected her septum by placement of the bony batting graft, and then I harvested her costal cartilage, and I'm placing bilateral extended spreader graft, and one quadriceps extension graft was placed, and two T grafting was placed, and one and then this is a glutathione costal cartilage shifted with my mold. And this is post-op result. As you can see, I could create a well-balanced dorsal line, and T was projected, and dorsal was nicely augmented. Another patient who developed cellulose due to recurrent epistaxis, and she developed chondritis due to cauterization, and thermal injury was the cause of her cartilage necrosis, and she developed the cellulose deformity like this one. So I opened her nose, and I found that her cartilage was badly damaged. So I reconstructed her cartilaginous septum by placement of the very strong cartilage framework with costal cartilage, and tip was augmented, and perichondrium was covered at the tip, and dorsum was also augmented with glutatized costal cartilage shaped with my Zhang cartilage mold, and as she is, I was able to create well-balanced, nice-looking nasal dorsum as shown here. Tip projection and dorsal augmentation was achieved. And as I said earlier, when the patient has badly damaged septal cartilage, and when the patient has big septal perforation, we cannot utilize the septal cartilage. In that scenario, we have to bypass the septum. So in that case, what we have to do is using the integrated columnar stroke plus dorsal implant. So I call this a bypass graft. This patient who had 5 times rhinoplasty before, I opened her nose, and I found that I could not dissect her septal mucosa because her septal mucosa was completely damaged. So I harvested the 6th strip, which has a natural angulation as shown here, and I dissected her anterior spine, and I made a hole with the drill, and then I designed a natural A-shaped implant from the 6th strip, and it was and I just closed the septal part, and then I placed this A-shaped implant over the cartilaginous dorsum, and then this caudal part was securely fixed with the anterior spine, and then this A-shaped implant was fixated securely with the cartilaginous dorsum, and then it was covered with perichondrium, and dorsal augmentation was done with. So I also placed a little bit of the fat graft here, and dorsum was augmented with the glutatized costal cartilage. Here she is. So as a result of this effort, now she has a normal looking nose. It's not perfect, but she was so happy with the surgical result. Another patient who was a boxer, worked as a boxer many years, and who also had a quite severely damaged septal cartilage, so I could not dissect his septal cartilage framework. So in this case, once again I utilized the concept of the bypass L graft. So I dissected nasal spine, and I to fix this new integrated electrode to the entering of the spine, and dorsum was augmented with a very thin sliced diced cartilage, thin sliced costal cartilage, and tip projection and dorsal augmentation was achieved. This patient is a GPA patient who came to me with a severe saddle like this. Once again, I harvested A-shaped, naturally A-shaped big costal cartilage from her sixth rib, and I designed a A-shaped implant, and the designed A-shaped implant was fixated to the anterior spine and fixated to the nasal cartilaginous dorsum, and dorsum augmentation was done with free diced cartilage. So I could reconstruct her nose in this way. So she became so happy about the surgical result. And this patient is from U.S. Who was a long-term cocaine user, ended up with a big population like this. In this case, we also cannot dissect the septal mucopericardium. So the concept of the bypass graft is once again useful for this kind of patients. So I opened the caudal septal mucosa, which is very, very restricted area. In that restricted area, I placed this caudal, the septal costal cartilage, the caudal part of the allograft, and then the dorsal implant was integrated with this columnar strut part, and then T graft was added, and perichondrium was covered, and dorsum was augmented with blue diced costal cartilage. Because this patient returned to US about 3 weeks after the surgery, this is the post-op what I have. He was quite happy with the surgical result. This is a patient who had severe contracture after the surgical rhinoplasty. Actually, he is HIV positive patient. I found that he has septal perforation, so I utilized the same technique for reconstruction of his nose. Sometimes we have the patient who has a severe pinched nose like this. In this case, the use of the ear cartilage composite graft is quite useful. I found this patient has badly ossified, too much ossified costal cartilage, so I could not use her costal cartilage for septal extension graft. So in this case, I used ear cartilage as a septal extension graft, and then this was mono rim graft for the pinched nose correction, and this is ear cartilage composite graft for pinched nose correction. And as a result, I could. It's not perfect result, but now she has a more smooth looking, more natural looking nostril, which is not that not that strange. And in many revision case, we have a limitation in pulling up the skin. So in that case, I call this as a relaxing incision. We can extend the incision of especially the lower part of the flap more inferiorly. Then we can easily pull up the skin. So I call this a relaxing incision, and this is a useful technique for reducing the tension during the reconstruction of the multiply revised nose. So especially in this case, who has nostril deformity and quite severe skin retraction, I use this technique to, as you can see, there is quite limited skin available skin right here. So I made a relaxing skin incision, and I could correct her skin, the nostril right here, from here to here. And the difficult problem in the rhinoplasty is retracted columella. In very extreme case, ear cartilage composite graft can be useful. This patient came to me with severely retracted columella who had 3 times rhinoplasty. So I extended her framework first. And then during the surgery, I realized that her columella skin was extremely thin, and I was wondering that I can really close her skin. And at the end of the surgery, during the closure, I realized that I cannot close her skin because every time I pass the needle, I found that the skin just break up. So it was very challenging decision for me, but I went to the ear and I harvested ear cartilage composite graft. It was difficult decision for me, but it worked. So I could correct her closed columella skin, and this is the result. And as you can see, the early possible result was not so good, but finally it healed in this manner. So the most difficult problem we have in revision rhinoplasty and deformed nose is permanently deformed or missing skin. So I want to emphasize that the most precious part in the nose we have to respect is the skin soft tissue envelope. In the worst scenario, we have to consider the reconstruction with forehead flap. So think about preserving the skin every time you do rhinoplasty. So this patient came to me with badly damaged columnar skin and a lower third. So I used forehead flap. This is not such a beautiful result, but this was the best option I could offer to this young man. Now he could return to his normal life. This was probably the worst deformity I ever experienced. She had 10 times surgery before. So I used the forehead flap. As you can see, her skin quality was extremely poor because she's a smoker and she got many rhinoplasties and she got multiple injection on the face everywhere, injection of the filler. So I used the forehead flap and I used coastal cartilage as a frame, and for the sake of time, I will skip this. And the only possible result looks quite horrible. And finally, after multiple revision operation, I could make this change. She's from very remote place of Korea, so I don't have good quality postal photograph. Yeah, dog bite is another problem we oftentimes encounter. This is the patient who referred from the Philippines, who bitten by a big dog. Came to me with this nose. So first, this was a full thickness deformity, so I have to reconstruct his skeleton and inner lining and outer lining. So skeleton was reconstructed with costal cartilage and septal cartilage, and part of the inner lining was reconstructed with ear cartilage, and the skin envelope was reconstructed with ear cartilage, forehead flap. So this is ear cartilage composite graft. And finally, all the outer lining was covered with forehead flap. So I just covered with forehead flap and one particular revision. That's all. So the Allah contour is not so smooth, but the patient was quite happy with the surgical result, and he didn't demand any further surgery. So um, I didn't consider any more surgery for this young man. So in summary, in my toolbox for the correctional severity deformed nose, I want to emphasize that for this the rhinoplasty for the severely deformed nose, you have to have the concept that this is a rebuilding a broken house. So you have to be able to rebuild the 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 pedestal, rebuild the pillar by septal reconstruction using the combination of two extended spread grafts and using one quarter septal extension graft. Sometimes, if it is not possible, then you should be able to exploit the technique of integrated columnar strut and dorsal graft, which is usually called as a bypass graft. And dorsal augmentation is also an important aspect of this maneuver. So my preferred technique is glued discostal cartilage shaped with my mold. And last but not least, it's very important to respect the skin soft tissue envelope. When it is damaged, it's really difficult. So relaxing skin incision and ear cartilage composite graft and forehead flap is an option we can use. Thank you for your attention.
Thank you for this plan. It was a wonderful presentation. I wanted to ask right now, is there any audience? Do you have any questions from the audience? If there are no questions, I will just ask one question. What kind of food is done for the Greenwood text fossil cartilage?
Dr. Thomas, I cannot hear you well.
What glue do you use?
Dr. Thomas, why don't you remove your earphone? Just talk to your.
Can you hear me now?
Okay, yeah, it's better.
Okay.
Without earphone.
Thank you. What glue do you use for the text cartilage?
Yeah, it's just favoring glue.
Okay, this is favoring. And since we don't have any other questions, shall we move on to your next talk?
Okay. Yeah.
Yes.
I'm sorry now. My mouse have a little problem. Okay.
It's okay, Dr. Jain. You can just wait for a couple of minutes.
Oh, it's strange. Okay. Can you see my slide?
Not yet.
Oh, I see.
Yes, Professor, it's visible now.
How about this? Can you see the septal extension graph slide?
Yes, yes, we can.
Okay.
Yes.
Yeah, let me start.
Yes.
Yeah, my second talk is about septal extension graft. Yeah, we as rhinoplasty surgeons all know that septum has tremendous importance on the height and angle and definition of the nasal tip. So the modification of the septum thus can cause the considerable change in the shape of the nasal tip. So let's think about this exemplary case. This patient came to me with the complaint of hump nose. What we can appreciate is that this patient has decent tip height, considering the average Asian nose. He has well projected nasal tip. It's mostly because of the fact that he has well balanced, well developed nasal septum. But when you consider this patient, he has quite underprojected nasal tip with quite acute nasolabial angle. This tip shape, fully developed tip shape, is mostly due to extremely hypoplastic and underdeveloped nasal septum. So the effect of a septal extension graft can be summarized as that this can enhance the tip support, and this maneuver can control the projection and rotation of the nasal tip, and septal extension graft can improve the shape of the nostril, and you can do many different things like you can advance the columella, and you can improve the nasolabial angle, and you can lengthen the nose. So basically you can do all different things in the lower third of the nose. So in this illustration, the septal extension graft can elongate the nose, the lower third. So in this case, in this illustration, what the septal extension graft can do is projection. And this end-to-end type septal extension graft, by using this, we can project, or we can derotate the nose. When we place the septal extension graft, there are basic premise that we have to understand. The septum is the pedestal on which we put the extension graft. So the septum should be stable and strong, and it's better to place septal extension graft. Untouched septum is the best, but oftentimes we place septal extension graft on the resected septum, which means on the L strut. So it's better to have a quite stable and strong remaining L strut on which we place septal extension graft. So this is an important concept. I think the advantage, merits of septal extension grafts are that it is invisible graft. What the invisible graft means that once we place septal extension graft, it is covered with a la cartridge. So that's what I mean invisible. It doesn't not visible through the skin because it is covered with a la cartridge. And the other advantage is that most cases it's added on the coronal septum. If it is placed from the anterior spine, it can help build the foundation. So I think these are merits of the septal extension grafts. So my indications for septal extension grafts are severely underprojected tip, a short nose, and alar concavity, nostril asymmetry, and tip ptosis. Let me explain the effect of tip septal extension graft. This patient who has tip ptosis and underprojected nasal tip, so I elevated her nasal tip and I raised her nasal tip. Tip projection was achieved. Tip rotation was achieved as shown here. This is done as shown in this illustration by placement of the septal extension graft. Alar cartilage dimension and location was changed as shown in this illustration. So the alar cartilage was placed here and it was brought up right here. That's why her tip shape has been changed from here to here. For example, in this case, who presented with the alar lobule concavity here, his alar lobule concavity is improved. This was achieved because of the septal extension graft, which was placed in the middle, and it stretched the concavity of the alar lobule because the septal extension graft placed in the middle, it caused projection and also caused the stretching of the lateral cross of the alar cartilage. So that's why, without using lateral crural strut graft, his alar lobule concavity is improved. So his tip is projected. At the same time, his alar lobule concavity is improved. This patient came to me with nostril asymmetry. Her nostril asymmetry is improved with placement of the septal extension graft. Her nostril asymmetry is improved by placement of the septal extension graft as shown in this illustration. By placement of the septal extension graft, new orientation, more symmetric orientation of the alar cartilage was achieved, centered by septal extension graft. That's why she has now more symmetric nostril shape. And she has derotation. In this patient who has obturned the nose before the operation, now his nostril show is decreased. He has derotation after the surgery. Yeah, this became possible by placement of the septal extension graft. So septal extension graft changed the orientation and the location of the alar cartilage from here to here. That's why his nasolabial angle is decreased, and that's why his nose look derotated. Here are my preferred septal extension grafting technique. I prefer using bilateral placement of the baton type extension graft. I prefer sometimes using unilateral baton type grafting when the patient has deviated nose. But the technique I prefer most is placement of the end-to-end coronal septal extension graft fixed with bilateral extended spread graft. Here is the example. This patient has a hump and under-projected nasal tip. So this is a septal cartilage. I placed 2 layers of the caudal septal extension graft centered by the septal cartilage. As a result, his septal tip height is increased. Tip projection was achieved. I also reduced his hump, so there's improved profile line. Another case, hump nose, under projected nasal tip. So I placed bilateral septal extension graft side by side, bilateral. So now she has much more balanced profile view. This is another case where I used unilateral type, baton type septal extension graft. She had hump and mildly deviated nose. I show a video. So I placed a unilateral baton type septal extension graft on the right side of her septum, caudal septum. So I intended to project her tip about this much. So there is a tip projection about this much, and hump reduction was done, and tip projection was achieved. So now she has more well balanced profile line. She also has deviation and mild hump. So I placed unilateral baton type septal extension graft, and hump reduction was done. This is profile view. As I said earlier, most preferred technique for me is placement of the bilateral extended spreader graft combined with caudal septal extension graft. My fellows always see this technique. They may be quite boring looking at this technique. I'm using this technique all the time. But the reason why I'm using this technique is this is quite flexible because by adjusting this height and the width of this technique, I can project, I can rotate, I can sometimes can rotate, derotate. I can do many different things. I like this technique because I can construct quite stable structure with using this technique. So this is quite versatile, stable. And one other thing is because this is end-to-end caudal septal extension graft, there's less risk of airway obstruction. If you want to have a really, really stable construct, you can add one more sliver of bone or cartilage to have one little more support here. And here is one surgical tip. During placement of the extended spreader graft, if you make a notch at the again, you can easily facilitate ease of fixation at the dorsal part. Then this excess part can be removed after fixation of this cartilage to the dorsal aspect of the L strut. So these are patients who benefited from the placement of the bilateral extended spreader graft and sandwiched by the one caudal septal extension graft sandwiched by the bilateral extended spreader graft. This technique is particularly useful for the cases like this who had tip ptosis, who needed a significant tip projection. So this lady was, although this was a primary case, I used costal cartilage for correction of her deviation and tip ptosis, and so I placed a bilateral extended spreader graft and caudal septal extension graft to project her tip and rotate her tip, and she was quite satisfied with the surgical result. So this combination of extended spreader graft and tip caudal septal extension graft is quite useful for derotation and correction of the nose asymmetry which is common consequences of the silicon nose, as shown in this case. And as I showed earlier, this is a robust technique for correction of nostril deformity, which is a common complication of the silicon rhinoplasty. So by applying this technique, you can easily correct the rotated, too much rotated nose, upturned nose of the silicon complication. And I mostly talk about the coastal cartilage rhinoplasty, but if you are uncomfortable for using coastal cartilage, you can use ear cartilage as a separate extension graft. But the problem of ear cartilage is that it's thin and it's curved, so it's not an ideal material for the separate extension graft. So in order to overcome this limitation, what you can do is you can combine this bone and your cartilage to straighten and to strengthen the curved ear cartilage. Then you can use this as a extended spreader graft. So this is intraoperative view of the composite ear cartilage plus bone graft. So in this case, I use a combination of the ear cartilage and bone graft because she didn't like to use coastal cartilage. Um, Earlier, said that strong ulcer is very important. So in that regards, so when we have to place septal extension graft on the remaining ulcer, it's important to reinforce the ulcer with bone grafting before placement of the septal extension graft. So let me share the video with you. In this patient, before placement of the septal extension graft, I placed a bony batting graft to reinforce the ulcer. And then I placed a bilateral septal extension graft. Then I can assure a stronger, more sustaining, supported, more sustainable septal extension graft. So this is positive result. And sometimes, most times we think about septal extension graft for tip projection, but the concept of the septal extension can be applied for dorsal extension. This is paper written is Dr. Chen, who visited me as for fellows for few months. And so I call this as a gap graft. If you want to dorsally extend the cartilaginous septum, if you just extend the cartilaginous, the extension, the spread the graft dorsally, sometimes if you just suture it, it just medialized, and if you should support it in order not to it the lower part to be too much too much divergence to happen. So you better keep place some gap graft in between so that it uh, stay more stable. So I call this as a gap graft. And so this is a wonderful way of extending the height of the cartilage dorsum. So I call this as a gap graft. If you have to have just place one extended spread on only one side, you can place one extended spread graft on one side, and then you place just one uh, side graft. I call it side graft. Yeah, this is another option for dorsal extension. This the example of the patient who underwent dorsal extension of the cartilaginous dorsum with this concept. So another case. This is another case whom I used gap graft for dorsal extension of the cartilaginous dorsum. Actually, I didn't augment her dorsum. With dorsal implant, I augmented her dorsum with the concept of dorsal extension of the cartilaginous dorsum. There are some important considerations I want to share with you. When we place septal extension graft, the septal extension graft should be big enough. If it is not big enough, what it does is just eliminate membrane septum, especially when the patient has a big membrane septum. If it is not big enough, what it does is just eliminate membrane septum. It just stiffen the nose. It does not have enough uh, effect of projecting the ala cartridges. So it should be big enough. And there are some factors that determine the height of the tip achievable receptor extension graft, and height of the codoceptal extension graft, and lower lateral cartilage shape, and proper approximation with the lower lateral cartilage factors that determine. Let me explain what I mean. And this means, yeah, we place the septal extension graft, but if the lower lateral cartilage cannot be stretched enough, our effort is cannot be realized. I mean, we have to reduce the height, the dorsal extension, septal extension graft. So the stretchability of the lower lateral cartilage is very important. So sometimes if it cannot be stretched, it cannot be stretched. I use dome division technique to cover the height of the septal extension graft. Yeah, this is an option. So it's better than having just projected septal extension graft over the dome of the ala cartilage. You always better to cover it with some ala cartilage. And when you have trouble in the stretching the lower lateral cartilage, you better dissect laterally, fully dissect far laterally, and then you can pull the whole ala cartilage. So it's very important to have a full dissection. But in some case, you cannot perform full dissection, but you still have a projected septal extension graft like that. Then you can cover it with tip graft like this. This can be another option. So, but you have to understand that in order to get good tip projection and good tip shape, sometimes septal extension graft alone is not enough. So I would say that desired tip projection cannot be achieved with the septal extension graft, and final tip shape can be suboptimal in some patient. In some patient, we need to have additional tip grafting. For example, when the patient has very round ala cartilage, you have to have additional tip grafting right here. For example, in this case, who has a relatively round ala cartilage, we can elevate the tip as this much, but in order to have a definition, we had to add little more tip grafting like this. Then we can have a better defined, better projected nasal tip. So in this case, who has rounded nasal tip and under projected nasal tip, after projecting her tip with a septal extension graft, I added tip grafting for better projected, better defined nasal tip. So in this case, on the fully defined nasal tip, I projected her tip with septal extension graft with additional tip grafting. I'll skip this. So here she is. So in this case, could not create her nasal tip shape only with septal extension graft. So this tip shape was achievable with the combination of septal extension graft and tip grafting. There are complications of septal extension graft. Nasal obstruction, tilted columella, nostril deformity, stiff tip. There are several others. Yeah, tip projection is quite common complication. It's really disappointing to have this, but it's reality. The early poster result was pretty good, but 1 year later, the tip projection, there is loss of tip projection. And in this patient, nostril deformity occurred. Nostril asymmetry developed after tip projection. In this patient, tip projection was achieved, but later he complained of nasal obstruction. It was caused by extended spread graft protruding through the left nasal cavity. So I had to trim down here through the endonasal approach. This patient didn't like the fact that after the septal extension graft placement, his columella became longer. Yeah, some patient is quite sensitive to the increased columella shows. So I had hard time for managing this the complaint. And infection. Tip can be quite stiff after the surgery. So you have to tell the patient before the surgery. That's very important. So in summary, septal extension graft is powerful and effective in tip refinement. You should apply this technique in well-indicated cases. You have to thoroughly understand the dynamics and pros and cons. Thank you for your attention.
Thank you, Professor Jan. That is very detailed presentation on how to use a septal extension graft, and I think you are pretty clear on how to use it with your videos and photographs. So, do we have any doubts with the audience? I don't see any questions online. Okay, Professor Jan, since we have no further questions, I mean, you had showed both your presentations with beautiful results with well balanced noses post operatively. And thank you for your wonderful presentations. Thank you for taking your time out. Professor Jang is a little busy today, hence we put both these topics at the beginning itself. And now I'd like to thank Professor, and we could move on to the next speaker.
Yeah, thank you for invitation. Thank you.
Yes. Next, I would like to introduce our next speaker, Dr. Uppal, Dr. Sandeep Uppal. He is a fellow of the Royal College of Surgeons of England and Ireland. His research and clinical interests have resulted in numerous publications in peer-reviewed international journals, as well as presentations at various international courses, workshops, and conferences. He is a section editor for Rhinology and Facial Plastic Surgery section of the book Symptom-Oriented Otolaryngology, Head and Neck Surgery. He has written several book chapters. He is the course director of 11 Days of Facial Plastic Surgery, an annual fresh in cadaveric dissection course. And he is conducting the next one in Feb of next year. He serves as the governing council of the International Federation of Facial Plastic Surgery Societies He is on the international board for certification in facial plastic reconstructive surgery. He is in the PAN, PRS. He is in the FRCS IT India. He is the national examiner and member of the Examination Development Committee for Otolaryngology Exit Examination, Singapore. So I welcome Dr. Sri on this.
Singapore, ladies and gentlemen, and welcome to this talk on the management of pseudohump nose in ASEAN patients. My name is Sandeep Uppal. I work at Kudekpo Hospital, which is a beautiful hospital in Singapore. Before I begin my talk, I want to take this opportunity to welcome you all to the 11th International Conference of Pan Asia Academy of Facial Plastic and Reconstructive Surgery, which will be held at Singapore from the 21st to the 22nd of Feb 2023 in conjunction with 11 days of facial plastic surgery course, which is our annual course comprising of 3 courses held one after the other. These are the 7th Singapore Advanced Rhinoplasty Fresh Frozen Cadaveric Resection course, the 6th Singapore Facial Rejuvenation Surgery course, and finally the 6th Singapore Facial Fracture, Orthodontic Surgery, and Soft Tissue Reconstruction Surgery course. We are lucky to have really famous and excellent facial plastic surgeons joining us during these 2 events, and I'm sure this is going to be an excellent learning opportunity for everyone. So please come and join us in Singapore. To register, you may use the following details. Please write to Ms. Jaislin Tan or contact us at the following email and website. Our learning objectives for this talk are to differentiate between a hump nose and a pseudohump nose, to identify the anatomical characteristics leading to pseudohump formation in a particular patient, and to devise a customized surgical plan to correct the deformity in each patient. A rhinoplasty surgeon has to be always mindful that the primary objective of rhinoplasty surgery is to create an attractive, normal-looking nose which functions well and does not have any stigmata of surgery. It is scientifically proven that the human eye and mind judges someone as being attractive in a fraction of a second. This is not surprising since increased beauty confers advantages socially, reproductively, and professionally. Attractive people are consistently judged to be nicer, smarter, and healthier. The patient's preferences are often influenced by what their community and peer group consider as standard and attractive. The patient will not only be judging themselves against this standard, but will also be perceiving society's judgment of them based on the standard. These perceived standards are very significantly influenced by culture and further by varying social groups' tastes within a culture. There are other cultural norms to consider which may impact patients' decision to undergo rhinoplasty. For example, in Chinese face reading, nose is considered as the house of wealth and health. Rhinoplasty surgeon thus needs to be mindful of these cultural nuances when planning surgery. Over the last few decades, different societies and cultures have started to value the unique identities and facial characteristics more, but globalization has led to greater convergence of opinion on universal standards of beauty. The modern society is a truly globalized one, and this has a definite impact on the perception of beauty. Mixed races and nationalities are the new norm, and this blending of traits often leads to aesthetically unique and beautiful outcomes. The fashion and entertainment industries manipulate facial features to create new representations of beauty and associated lifestyles and social worth. These representations of exceptional beauty then help to define societal concepts of aspirational facial beauty and influences patients' desire to alter their nasal shape. This concept of borrowed beauty is very much applicable to the ASEAN context and influences patients to undergo rhinoplasty for aesthetic reasons. Tessier noted that harmony or disharmony does not lie within angles, distances, lines, surfaces, or volumes. They arise from proportion. It is true that no universal parameter can define ideal nasal aesthetics across cultures and ethnic backgrounds. A rhinoplasty surgeon must understand concepts of beauty defining cultural and ethnic identity and adapt to patients' surgical desires, keeping in mind the unique underlying anatomy. This poses a surgical challenge in cosmopolitan societies with increasing migration. The surgeon must understand the most striking facial features of different ethnic groups, as well as patients' aspiration of beauty for successful preoperative analysis, surgical planning, and assessment of postoperative results. One common reason for a rhinoplasty consultation in Asian patients is the correction of pseudo-hump deformity. Nasal morphology and the underlying anatomy varies between different ethnicities. Correction of pseudo-hump nose requires an appreciation of the relationship between surface aesthetics and underlying anatomy. The study of facial characteristics in average composites of different races has shown that these proportions, like the horizontal thirds and vertical fifths, the intercanthal distance, the alar base width, the midfacial height, the dorsal length of the nose, tip projection, the radix position, and various facial angles like the nasolabial angle are different in different races. As a result, there is a greater appreciation of the differences in proportions between different ethnicities. To understand the pseudo-hump deformity, it is important to pay particular attention to the aesthetic landmarks on the profile view, such as the glabella, radix, rhinion, tip, subnasale, pogonion, and menton. These landmarks then influence angles studied during rhinoplasty analysis, such as the nasofrontal angle, the nasal angle, nasolabial angle, facial convexity, and total facial convexity. The profile view is an important one to consider during rhinoplasty surgery. It is my experience that a straight nasal profile line between the tip of the nose and the frontal angle is generally considered to be more desirable in Asians as against Caucasians, in whom the profile at the rhinion, being located a few millimeters posterior to this line in women and slightly anterior to this in men, is often considered more desirable. In a hump nose, the nasal bones, the dorsal nasal septum, and the upper lateral cartilages are prominent at the rhinion, whereas the radix and the tip are in the ideal position. Surgery then requires resection of the bony and cartilaginous hump to correct the profile. A pseudo-hump nose, on the other hand, is slightly different. In a pseudo-hump, the tip or radix or both are underdeveloped and underprojected. The tip is often under-rotated or ptotic, and as a result, the middle of the nasal dorsum appears to be over-projected. This over-projection may be quite subtle or quite pronounced. Nasal tip shape and projection is largely determined by the position, size, shape, and integrity of the lower lateral cartilages. In Asian noses, the alar cartilage is often small. The alar cartilages are often weak as well, and this causes underprojection of the tip. In Caucasians, the height of the alar lobule should be equal to the height of the tip lobule according to the neoclassical canons of facial beauty. But in patients in my neck of the woods, The tip lobule is often smaller due to small and weak alar cartilages, leading to poor tip projection and pseudo-hump appearance. According to Caucasian norms of ideal tip proportions, the height of the infratip equals the height of the columella and the premaxilla. However, in Asians, the infratip lobule is often smaller than other parameters, which contributes to decreased tip projection. Extrinsic factors affecting tip projection include a small anterior nasal spine, small and weak septal cartilage, and posteriorly placed anterior septal angle. Underdeveloped nasal bones lead to the rhinion being underprojected. The weak and small septal cartilage bends under the weight of the thick overlying skin and soft tissue envelope, leading to deviated nasal septum and poor tip projection. Tip support and projection may also be compromised from traumatic septal injury, causing deviation and weakness of the caudal septum, leading to poor tip support. Patients may also have maxillary hypoplasia. The depth of the radix has an impact on the start point or root of the nose, the nasal length, and nasofrontal angle. Deep radix gives the appearance of a small nose and acute nasolabial angle, and vice versa. The radix is present anywhere from the level of the mid-pupil to the upper eyelash line in Asians. This is an important consideration when deciding on the radix height in Asians, as a very high radix may lead to an ethnically inappropriate result. Hence, the surgeon has to balance the patient's desire of having a high radix with the need to produce a natural result. It is very important to differentiate a hump nose from a pseudo-hump nose, as wrong diagnosis will lead to wrong surgery and suboptimal aesthetic results. This can be done by deciding on the ideal radix height and start point of the nose, ideal mid-dorsal height, as well as tip projection, and then drawing a line joining these points to give the desired profile. This then helps us to decide on the amount of augmentation required in the radix areas, as well as the tip areas, and any resection that may be required in the mid-dorsum in a pseudo-hump nose, or in the mid-dorsum in a hump nose. Morphing is a useful tool to have a discussion with the patient regarding their aesthetic desires and the proposed surgical plan. This lady is quite tall. She has Marfan syndrome. She has a hump nose and poor tip projection and tip derotation. And the simulation on the right shows only hump reduction with a reasonable result. Here, the simulation on the right shows increased tip projection along with hump reduction, leading to an even better aesthetic result. If this patient is wrongly diagnosed with a deep radix and a pseudo-hump, and only the radix is augmented, the patient will end up with a Romanesque appearance, which is aesthetically not pleasing. In a pseudo-hump nose, an underdeveloped low radix is easily addressed with a tissue graft placed in a precise subperiosteal pocket created at the radix. This may be a cartilage graft, a fascia graft, or other soft tissue graft. Often, a small hump reduction is needed for establishing profile harmony. If the tip and middle third needs augmentation, extended spider grafts placed anterior to the level of the native septal cartilage, combined with a septal extension graft, can help to form a sturdy L strut to project the tip and increase the height of the middle third of the nose. The septal extension graft and extended spider grafts may be harvested from the septum or the rib. The aim is to change the position of the anterior septal angle, pushing the tip more anteriorly, and changing its rotation by mounting the medial crura more anteriorly on the nasal septal extension graft. The tip may be augmented further by shield graft and tip grafts. All these maneuvers combined help to alter the radix height and position, as well as the tip projection, thus changing the nasofrontal angle and nasofacial angle. Let us now look at a few examples of patients with pseudohump deformity. This young man has a typical pseudohump due to poor tip projection. The pseudohump is quite apparent on the 3/4 view from both the sides. The nose is also deviated to the left from previous trauma. There is also a bony and cartilaginous spur in the rhinion on the right side. There is also a caudal septal deviation to the left. In this patient, I used the external approach. Crushed cartilage radix graft was used. Dorsal bony spur was excised. A septal extension graft with tongue and groove technique along with cap and shield graft was used to increase tip projection. Medial oblique and lateral osteotomies were performed to straighten the nose. After surgery, the nasal height and tip projection are in harmony and the pseudohump has been corrected. Here are the preoperative and postoperative 3/4 views. As you can see, the pseudohump has been addressed and he's quite happy with the results. There's a marked improvement in proportions between different parts of the nose. The nose looks straighter and softer, something that is more desirable in Asians. The dorsal bony spur has been addressed, thus improving the brow tip aesthetic lines. The base view clearly shows that the height of the infratip lobule has increased, and there is greater proportion between the infratip lobule and the columella height. Here is another patient where the rhinion is relatively high and the tip is under projected with no supratip break. This patient has had previous trauma and as a result the right nasal bone and upper lateral cartilages are depressed. Because of this, the rhinion appears high, especially from the right 3/4 view. The nasal bones are deviated to the left and the middle and lower third of the nose is deviated to the right. This is a result of previous trauma, leading to depression of the right nasal bone and upper lateral cartilage. On base view, the infratip lobule appears to be small, and there is also a caudal septal deviation to the left. Here you can see the preoperative view on the left and the postoperative view on the right. The patient is 9 months after the surgery. In this patient, I used an external approach. I used a septal extension graft along with the tongue and groove technique to increase tip projection. Osteotomies were performed to straighten the nose. Cephalic trim along with tip sutures and cap grafts were used to increase tip projection and to refine the tip further. You can see here that the tip projection has increased because of increase in height of the infratip lobule. The septum looks straight. The nose looks aesthetically more pleasing after surgery, and the tip is no longer under-rotated. The pseudohump has been addressed, and she has a nice supratip break, which she is happy about. Here is another patient with a pseudohump. You can see that the patient has a small tip lobule and an underprojected tip, which is the main reason for his having the pseudohump. This gives the appearance of a hump in the rhinion area. However, this is in fact a pseudohump. The upper third of the nose is deviated to the right, and the middle and the lower third are deviated to the left. There was a small bony spur on the right nasal bone. The head-down view shows that the brow tip aesthetic line is broken on the right side. The caudal septum was also found to be deviated. In this patient, I rasped the bony spur and performed osteotomies to straighten the nasal bones. Crushed septal cartilage was then used to augment the dorsum. I used a cross graft along with tip sutures, shield and cap grafts to increase tip projection. All these maneuvers helped to address the pseudohump. The main reason for improvement in the appearance of the nose, that is correction of pseudo hump, is increase in tip projection. Base view shows better proportion between the infratip lobule and the columella. The nose looks straighter. There is improvement in brow tip aesthetic lines. The appearance on the 3/4 view is aesthetically more pleasing, and he's quite happy with the results of surgery. This 17-year-old young man has a typical pseudo hump nose resulting from poor tip projection and a low radix. He also has caudal septal deviation resulting from previous trauma, which was contributing to decrease in tip projection. The upper third of the nose was deviated slightly to the left, and the middle and the lower third to the right. He also has a flat, ill-defined amorphous tip due to increased interdomal and intradomal angle of divergence. This is the 3/4 view of the patient. On raising the skin and soft tissue envelope, the domes were found to be ill-defined and flat as expected. The septum was found to be deviated to the left due to its curvature. Inferior tip of the cartilage was excised to straighten the septum, and then the posterior septum was harvested for grafting. In this patient, I used an extended spreader graft on the right side of the septal cartilage, and a septal extension graft was placed on the left. Along with this, I performed a cephalic trim, preserving 7 mm of lower lateral cartilage on both the sides. A shield graft was used to increase tip projection. This was supported by tip batten grafts, as well as 2 cap grafts to increase tip projection. Crushed septal cartilage was used to augment the radix. And bilateral, oblique and lateral osteotomies were performed to straighten the nose. The profile improved after surgery. The pseudo hump has been addressed. The tip projection and rotation has increased. The brow tip aesthetic lines are not distorted anymore, and the tip is more well defined. As seen on the base view, the nostrils appear to be more symmetrical now. The tip is better defined, and there's better proportion between the tip lobule and columella. As a result of the spreader grafts, the middle vault is no longer pinched. The right upper lateral cartilage and nasal bones have been lateralized, thus opening up the internal nasal wall. The patient is very happy with the functional as well as the aesthetic results of surgery. This next patient is the last patient that I'm going to present. This pretty lady has a classical pseudo-hump deformity due to a deep radix and poor tip projection. The root of the nose was low at the level of the inferior lid margin. There was a slight bony prominence at the rhinion from previous trauma. She also had an ill-defined tip, which she wanted to be refined. In this patient, I used crushed septal cartilage to augment the radix and a caudal septal extension graft to bring forward the anterior septal angle. Osteotomies were performed to straighten the nose, and I excised the bony and cartilaginous protuberance at the rhinion on the left side that had resulted from previous trauma. Transdermal and interdermal sutures along with cephalic trim were used to improve tip definition. This whole complex was then mounted and sutured onto the new anterior septal angle. This, along with 2 cap grafts, were used to increase tip projection and change tip rotation, thereby improving the nasal proportions and addressing the pseudo hump deformity. The nose looks much better on the 3/4 view. As you can see, the tip definition has improved. The tip projection also improved after surgery. The nose looks straighter after surgery. The brow tip aesthetic lines are also symmetrical between the two sides and are no longer distorted. The tip looks more refined. She is very happy with the results of the surgery. The pseudo hump has been addressed as she wished. So the take-home message is that careful analysis of the radix, rhinion, and tip help to differentiate between a hump and a pseudo hump nose. Morphing, I find, is very helpful to identify the problem and help with the surgical planning as well as patient education. Pseudo hump correction requires one or all of the following: radix augmentation, tip augmentation, and very occasionally a slight hump reduction. Thank you very much for your attention.
Thank you, Dr. Upal. That's a great presentation on how to manage pseudo hump. Move on to the next presentation. I would like to introduce Sajid. He is a noted ENT and facial plastic surgeon from South Korea. He is a director and professor of the Department of Gynecology, Fusion University College of Medicine. He is a member of the Korean Society of Facial Plastic and Reconstructive Surgery and the Korean Society of Gynecology and Ethnic Surgery. He had a two-year fellowship as a visiting professor at the University California Medical Center, Sacramento. He passed the board examination of the International Board of Facial Plastic and Reconstructive Surgery in 2013 and the International Board of Cosmetic Surgery in 2007. Every year, he has been organizing the International Choosing Aging Face Symposium, which is focused on surgical facial rejuvenation. He has published 60 papers and 5 facial plastic books, and he has had over 100 live surgeries with over 3 medical presentations for rhinoplasty, blepharoplasty, facelift, roll-in, and reconstructive surgeries internationally. Let's move on to the presentation by Dr. Choi.
Good afternoon, everybody. This is Jiun Choi from Joseon University Hospital. Today, I would like to talk about surgical tips for the management of the wide ala base. For the preoperative evaluation from the frontal view, we need to check the ala flaring. Ala flaring means 2 millimeter wider than intercanthal distance, like this. From the basal view, we need to check the ala side wall, ala base, nostril seal, the lengthening of thickness. Also, we need to check the shape and size of the nostril. Usually, tip projection makes the ala base looks narrower, so ala base surgery performed after finish the tip plasty. The ala base reduction is a final step in the rhinoplasty. This case, before the operation, I planning the ala base surgery, but after tip projection, you can see the ala base looks narrower, so I don't need ala base surgery after tip plasty. Now I would like to introduce my paper about the classification of the ala base surgery. This is my classification of the ala base surgery. Actually, in the past, there is no classification of the ala base surgery, so it is very difficult to apply the ala base surgery, especially in Asia. Type 1 means the alar flaring. Type 2 means the wide alar base. Type 3 means the alar flaring and wide alar base combined. Type 4 means the thick alar. Type 5 means the type 1, type 2, type 3, type 4 combined. Type 6 means the alar hooding. In case of type 1, we can apply the lateral alar reduction. In case of type 2, we can apply the nasal seal reduction. In case of the type 3, we can apply the lateral alar reduction and nasal seal reduction together. In case of type 4, alar sidewall excision. In case of type 5, we can combine. In case of type 6, we can apply the vestibular skin excision. This is my classification of alar base surgery. For the design of the alar base surgery, at first, the nasal seal means the inside of the alar base. At first, we need to check the most lateral and inferior of the nasal seal. After that, we can extend this line following the alofacial sulcus like this. This line will be the reference line of the alar base surgery. In case of the alar flaring, we can resection the lateral portion of the alar base. In case of the wide alar base, we can resection of the middle portion of the alar base. In case of type 3, we can remove together. This is illustration of the type 1, type 2. This is a reference line. Also, lateral portion of the reference line is type 1. Middle portion of the reference line is type 2. Combination of type 1 and type 2 is type 3. This is the illustration of the alar base surgery. This is type 1. At first, we need to draw the reference line. After that, second line will be the parallel with first line. Third line is following the alofacial sulcus. After that, finally, we can resection of the wedge resection of the mucosal excision together. After this is a design of type 1. This is design of type 2. At first, we design the reference line. The second line parallel with reference line. After that, we can add some wedge mucosal excision inside. This is the illustration of the design of type 2. This is the type 4 thick alar. At that case, we need alar sidewall excision. The design, at first, we need to design the inner margin of the alar rim. Second line, parallel with first line. Third line is following the alofacial sulcus. After that, we can excision the skin wedge style. This is a type 5, design of the type 5. We need to lateral alar reduction and nasal seal reduction together, like this. In case of the hanging alar, like this, we can apply the vestibular skin excision like this. Sometimes we can combine lateral direct skin excision. Extremely wide alar base, we can combine the bunching stitch. Bunching stitch using a 3/0 nylon or 4/0 PDS big needle, we can apply the figure 8 suture like this. The bunching stitch, it can reduce the tension and prevent scar formation. Also, additional narrowing is possible. This is a type 3 wide nostril. In that case, we can apply the lateral ala reduction and nasal seal reduction together. This is before and after operations. This is another type 3 before and after operation. We can reduce the size of the nostril. This is another type 3. This is a type 2 wide seal. In case of the type 2, we can apply the nasal seal reduction like this. At first, we design the reference line. After that, we can extend the skin middle portion of the reference line like this. You can see the before and after operation. The shape of the nostril was changed. This is another type 2. You can see the change of the nostril shape. This is another type 2. This is another type 2. This is type 5. You can see the thick ala and wide ala base. This is design of the type 5. We can excision the side wall and ala base together before and after operation. I want to show you the video. After finish the rhinoplasty, T-plasty, now I'm drawing the reference line. At first, I check the most inferior and lateral the seal position. After that, second line usually parallel with first line. Now I incision of the ala base. After that, I perform the bleeding control. After that, I remove the ala base. Ala base surgery always should be conservative. If you wanna remove 2 millimeter, it's better to remove 1 millimeter. After that, I apply the stitch, usually 5 or 6 or nylon. After that, we can finish the operation. Usually, we remove the stitch POD5. This is type 2. This is type 4. Before and after. Using Adobe Photoshop program, we can simulation the elevation. We can communication with the patient before operation using a Photoshop. This is my clarification of the elevation surgery. I published this paper in facial plastic surgery clinics of North America. If you want more information, you can read my article. Thank you for your attention.
Thank you, Professor Choi. That was an interesting session. Interesting to see patients that you showed. Do we have any questions in the audience? Since we don't have any Uh, our next speaker is Dr. Kim. Dr. Kim. Dr. Kim is a certain CEO of the Research. He did his MBA and PhD College of Medicine, Seoul National University. He did his facial plastic surgery at SU. He's a clinical instructor at Seoul National University. He's visiting University of Pittsburgh and assistant professor at the College of Medicine at University. He is a board member of the and it's without spending more time on this, I would like to welcome Dr. Kim. Dr. Kim, it is a pleasure to meet you online after a long time. And I would like to hand the mic to you.
Hello, do you hear me well?
Yes, Dr. Kim.
Okay,
Welcome.
good. Can I start now?
Yes, of course. Yes.
Okay, thank you very much. Okay. Okay. Hello, I'm Insan Kim. Of Hello, I'm Insan Kim of Bienyoung Aesthetic Clinic in Seoul, Korea. I want to talk about the pitfalls of augmentation rhinoplasty with autologous cartilages. There are many materials for total augmentation and many autologous materials, but only the autologous rib cartilage is only a comparable option to alloplastic implants for major augmentation. For alloplastic implants, silicone is widely used for long and still most popular, I think. And EPTFP, in Korea, it showed some waned popularity recently. Rib versus silicone. Rib has many advantages. It is autologous, so it is appealing to patients who have fear of foreign materials. And also, it can give some strong tip projection, and there's less chance of infection, even if it is possible. And there's no chance of capsule formation. That's the advantages of the rib colleges. But disadvantages of rib colleges are not a few. Calcification, chest scar, there's a chance of infection also. And if it is infected, the result can be devastating. It is recalcitrant to antibiotics, and offending organisms are frequently very virulent, such as the MRSA, Pseudomonas, or anaerobes. And carved rib has a problem of visual contour, warping, inflexibility, fracture sometimes. So many doctors use the diced rib colleges recently, but diced rib has other problems also, such as the obstruction, irregularity, and insufficient amount sometimes when the rib is heavily calcified. Major problem is the difficulty of carving and difficulty of insertion, difficulty of revision operation. These are the main problems of the diced rib colleges. In this case, I did the total augmentation with the carved rib, but it showed some warping. And another case of the warping, another case of warping. So this is a well-known problem. And in this case, she had the rib augmentation before, and the rib graft was very bulky, so obstructing the airway. So I did revision operation. So this is another problem of rib cartilages. Okay, and in this case also, I did augmentation using rib cartilages, carved the rib, and it can show some visibility problem in this case. So you can see the visual contour of the rib on the dorsum. So I had to do revision operation using diced rib cartilages. So in this case, you can see after revision, you can see the nice result. And another problem is the chest scar. It can be not very visible, but in some patients it's still very visible. So that's the problem. Calcification is very common problem of rib cartilages. In this case, she had silicone augmentation before, so I did the revision operation. And you can see the L-shaped silicone implant inside. So I did the revision operation using rib cartilages, but you can see the rib was very heavily calcified at the center, so available rib was not very much. So this is the problem. Anyway, the result was not very bad, not very bad. So actually, it was very nice result in this case. But sometimes the calcification of the rib is very heavy, like this. So in this case, this rib was useless. So this is the problem of the rib. In this study, the calcification rate was about 40%, but the older patient group, it was almost like 60%. So pretty much frequent rate of the calcification. And another study, overall calcification is 50%. But fortunately, meaningful calcification, which was defined as 26% or greater calcification of the volume, was not that much, but still about 20%. 20% is not a few, in my opinion. So this is the problem of the rib cartilage. And in this patient, she had silicone augmentation before, so I did revision operation using diced rib cartilages, but her rib was a little bit brittle, a little bit calcified, so that was the problem. So this is the 2 months after the operation. You can see the nice augmentation of the dorsum. But 3 months later, you can see some absorption of the graft, dorsal graft. You can see the some absorption. But 5 months later, the absorption is pretty much almost gone. So that was the problem. So I had to do revision operation with silicone again in this patient. So that impossible to carve, and the procedure is very long, and it is difficult to insert, difficult to place, and difficult revision, difficult removal. Also another problem, absorption, visible or palpable irregularity. These are the problems of the diced rib cartilages. So diced rib cartilages in fascia is used in Western countries pretty frequently, but it is like sac, a spindle shape, so no individualized carving is possible, and laborious procedures. These are the problems. Another technique is the diced cartilages with glue, but commercial fibrin glue has a problem because it contains bovine thrombin inside, but this bovine thrombin can induce some allergic response, sometimes life-threatening coagulopathies, even anaphylaxis. Actually, I had a case of anaphylaxis in my patients. And there are some minor agents inside causing hypersensitivity and toxicity. So actually, aesthetic use is off-label. So there are many commercial fibrin glue, equine and bovine products inside. Bovine thrombin can cause production of thrombin antibodies, maybe up to 20% of patients, and cause temporary erythema. This is pretty common, I think. So you can see temporary erythema of the tip or the dorsum. This is very frequent phenomenon, I think. So they're having attempts to develop autologous fibrin glue, but it was not very successful because it was very difficult to obtain and extremely long and complex protocols usually. But some advantages: reduce the risk of contamination, immunologic response, some biologic beneficial effects like promoting wound healing, other things. But disadvantages are very clear: low reproducibility, individual variation, and lower adhesion strength. These are the problems. So it can be obtained from different sources: PPP, PRP, or PRF, different kinds. But you need thrombin also. You can obtain autologous thrombin, but it's very difficult to obtain also. So these are that is the problem also. You can use the bovine thrombin, but in that case, the problems the same as the commercial fibrin glue. So my experience, I was very enthusiastic at first using PRF, some initial encouraging results, but I was disappointed sooner or later because of problems of absorption, irregularity, individual variation. So this is the dice rib with autologous fibrin glue. In this case, I used the dice rib collages, which was mixed with the autologous fibrin glue. See, and I was inserted like this. So this is the result: pre-op, post-op, pre-op, post-op, pre-op, post-op, pre-op, post-op. And also another case. In this case, I used the grinding machine to make dice rib collages. And okay, so dice rib was obtained like this, and it was mixed with the autologous fibrin glue, and this is the result. So pre-op, post-op, pre-op, post-op, pre-op, post-op. And another case, she had a silicone augmentation before, so I did the revision operation using dice rib collages. You can see the nice result. And in this case, dice rib collages with allodome together at the bottom. There was allodome. And so you can see the nice result also. Another case of revision operation, silicone inside. I did revision operation using diced rib, and this is the result, very nice. And another revision operation using diced rib. So you can see the nice result. And the diced rib colors can be injected like this, actually. It's like toothpaste, right? So this technique is not a new. They can use special instruments for this, and you can inject the diced rib like this on the dorsum. Actually, this technique was reported very early in 1960s, and you can see that's college injection like this, dosal augmentation, ala basal augmentation, So in this case, I used the injected tassm for the dorsal augmentation. You can see the very nice result. So injected collagens can be like wood chip, a conglutinate mass, and it is very pliable, no problem of a late show, and very short operation time. This is the major advantage of the injected cartilages. But the problem is the irregularity. The strip collagen has a problem of irregularity. So you can see irregularity on the dorsum, irregularity, irregularity. You can see this is the problem of the rib collages. And this case was contracted nose. So I did augmentation using dicer rib. This is the 1 month after the operation. You can see the nice result. But she had experienced some infection of the digestive rib, actually. So digestive rib can be infected also. In this case, after the infection, she lost some volume and she lost the tib elongation a little bit. But still, it was not very bad. But I want to say that digestive rib can be infected also. In this case, digestive rib also can see, but irregularity problem of the dorsum, you can see. So there are many problems related to the rib cartilages. If it is infected, the result can be catastrophic. I will show you some cases. So usually I use the spreaders and struts using rib cartilages. In this case, spreaders and strut I did using rib cartilages. But if the rib cartilage was infected, and you can see columnar retraction and hyperemia on the dorsum. And in this case also, I did big augmentation. 4 months after, it was nice. But 1.5 years later, you can see some columnar retraction. So I had to do revision operation. When I opened, I found complete loss of the columnar segment of the rib graft and also obstruction of the coral septum. That was the big problem. So I had to do another revision operation using another rib. And this is 1 month after the second operation, but it's not very perfect. The result is not very perfect because of the skin contracture. So it's not very beautiful. So I had to do another revision operation. So this is after the third operation. It's much better, but still not perfect. So the rib callus infection is very difficult problem. So this is, you can see rib callus infection, complete loss of the tip augmentation and columnar retraction. This is a very painful experience for me. And you can see complete loss of the columella and tip. So I had to do, you can see the exposure of the rib graft. I tried the primary closure, but I failed. Loss of columella skin. So I had to do composite grafts, but it failed. And I did the buccal nuclear flap and skin graft, but still it was not very perfect. Another case. So of the rib infection, in this case, the columella segment was infected, and you can see the loss of projection and columella retraction. So another case, infection and loss of columella skin and columella retraction. So you can see loss of tip projection and columella retraction. So I had to do revision operation with another rib. So this is the result after the revision operation. So maybe rib infection can be from tension necrosis, ischemic necrosis, poor blood supply, dehiscent wounds, biofilm, I don't know, contaminated field, contaminated instruments, I don't know. There will be many etiologies. So I have some experience with silicone implants. So I want to ask a question. Is rib really comparable to silicone? I don't know. I don't think so, actually. Silicone is aesthetically superior. It is a little bit prone to infection, but in my experience, it's very rare, actually. Even in my cases, rib cartilage is more frequently infected. Extrusion, in my cases, in recent 10 years, no case for me. Capsule formation, but it's not harmful in most cases. Other minor issues are seen to rib cartilages. So in this case, I did revision operation, silicone augmentation. For the tip, I used the rib cartilages, but for the dorsum, I used the silicone implants. So you can see the nice result. Another case, revision operation, removal of the L silicone inside, and did revision operation using silicone augmentation for the dorsum, and for the tip, I used the rib cartilages. Another case, silicone augmentation dorsum, and for the tip, I used the rib cartilages. So the difference with the Western rhinoplasty, usually in Western countries, is mainly partial augmentation and different aesthetic standards and patient expectation. So usually partial augmentation, so diastatic cartilages are enough. But in Asia, is major augmentation. So recalling recent 10 years for me, silicone, very rare problems, no extrusion at all. And but new colleges, painful memories for me and potentially catastrophic results. So in summary, uh, I agree, diastatic is a good material, but it's not perfect and it's not complication free. So still my primary material of choice for primary and uncomplicated secondary rhinoplasty will be silicone implants for me. Thank you very much.
Uh, Thank you, Dr. Kim. That's a good presentation.
Okay.
And let's questions. Well, I have one question from Dr. Kam. Which indications do you recommend for the use of diced cartilage?
I'm sorry, I cannot hear you very well.
What indications will you recommend for diced cartilage? Where will you use diced
Okay.
cartilage?
Some patients want just autologous materials only for their noses. So in that case, I recommend diastatic cartilages.
But will you use when will you use solid cartilage and when will you use diced cartilage?
Recently, I used the diastatic cartilages, but sometimes when I make operation very quick, very simple, then I just use the simple carved block of the rib cartilage. Other cases, I use the I prefer diastatic recently.
Yes, doctor. And do you use any other glue other than fibrin glue? Do you use only autologous fibrin glue?
No, just I use. Sometimes I just use the PRF.
Okay.
Without a thrombin, sometimes it's very sticky. So and
PRF.
some, yeah, without thrombin or with thrombin.
Okay.
Autologous fibrin.
Do we have any other questions from the audience? Is Dr. Kaur? Dr. Kao, maybe you can have a word with Dr. Kim. Well, it looks like Dr.
Thank you,
Kao is
Professor
connected.
In-Sang Kim. Thank you very much for your excellent presentations.
Thank you, Dr. Kao.
I always learn much from your technique. May I know you prefer to use the stylistic silicone implantation, right?
Right,
So
right.
How about the long-term result? Because we concern about the capsule formation and the contraction. So how, in your experience, how do you prevent the contraction of the nose using the silicone implants? Thank you.
Yeah. So I have some patients, 10 or more years before, when I 10 years long follow-up period of some patients after the silicone augmentation, but no, I don't see any problems. Maybe the secret of the low complication will be silicone augmentation is only for the dorsum. For the tip, you have to use the autologous cartilage like septal or ear cartilage. And for the dorsum, no problem at all. So only the mobile part is a problem when it is contracted like this. So mobile part is the problem. So for the mobile part, you have to use the autologous cartilage. But for the dorsum, silicone, no problem, I think.
Thank you.
Okay.
Thank you. We are looking forward to see you in Seoul.
Okay, see you in Seoul. Thank you.
Thank you so much, Dr. Kim. It was a wonderful presentation. Dr. Kim's presentation on anaplasty session is so I would like to thank Dr. Kao for hosting this whole program. And I can see the audience, Dr. Jerry, Dr. S. And nice to meet you. And next, I'd like to hand the mic over to Jess. Maybe you can take over. And if we have any other things.
Thank you, Dr. Thomas and all speakers sharing. Now let's have a 15 minutes break now. So we have prepared meals and drinks at the back in the room for all the on-site participants. So please enjoy and see you later. Thank you.